Great question. So we, first of all, there were no historical controls. This is one of the novel aspects of our trial. Was this really the first data of Niraparib in previously untreated men with prostate cancer. All the data is in, and the current approvals for the drug are in the advanced prostate cancer setting, metastatic castrate-resistant prostate cancer. So our trial was novel in that it was moving it up in the treatment pathway. We did not see any dramatic pathological responses. We did see some molecular as well as radiographic responses, but that's why the trial did not actually meet its primary endpoint, which was pathological. When we looked at, we stratified at least the PSA responses by their baseline genomics. It does appear that men with BRCA2 altered prostate cancer, and particularly in combination with other genes that are involved in other DNA repair pathways. So one of the most profound responses we saw was in a gentleman with a germline BRCA2 and then a somatic ATM mutation as well. A second responder also had Lynch syndrome, so he had germline mutation in MSH2, but then also had a somatic BRCA2 alteration. So it seems like potentially that dual loss of DNA repair enzymes and pathways may predict a stronger response, at least in the previously untreated prostate cancer setting. Well, we don't really know that. I mean, yeah, about half the group ended up being organ confined at the time of prostatectomy. The best responder did have borderline T4 prostate cancer that was questionable whether he was a good surgical candidate. He had a good response. We saw radiographic downstaging, and he was able to undergo the operation. But it's unclear if there was any impact actually on the margin status or if it was just the nature of the disease. I think it will. The key is identifying who is going to benefit, because clearly our current knowledge we don't have the current knowledge on whose benefits. The single genes are not necessarily entirely predictive, so we need a better sense of, we need a better biomarker that'll predict who will respond. I think clearly there is a subclass. It's probably low percent, but a subclass of men that will respond. We also have to work out the ultimate, although the timing and length of treatment prior to prostatectomy. Well, we're working on a broader molecular analysis of the men that were in the trial and the pathology to look at predictors of response, but also it looks like in one of the gentlemen we did look at, there was an early reversion mutation which has been described, and that's likely a resistance mechanism. We were a bit surprised on how quickly that arose on treatment. It arose within 6 weeks. We don't know the ramifications of that quite yet, nor do we know if we see that in the other patients on the trial. So we're currently running those studies, so hopefully there'll be more to come.